All right, so thanks very much everybody for joining us tonight for this session of the Cleveland Clinic Prostate Cancer Awareness Month virtual series. Today we'll be talking about surgical treatment options for localized prostate cancer. My name is Nima Almasi. I'm one of the urologic oncologists in the department here at Cleveland Clinic. I'll be moderating today's session. For those of you who are attending live, you can submit questions through the chat function. And we'll submit those questions to our expert panel to review. So please feel free to pass along those questions throughout today's session through the chat function, okay? So I'm gonna start off first by introducing our expert panel. So first is Dr. Sam Haywood. He's an associate staff in the Department of Urology at Cleveland Clinic. And he is a subspecialist with training in urologic oncology, meaning he specializes in the treatment of urologic cancers. Second is Dr. Christopher Waite, who serves as the director for the Cleveland Clinic Center for Urologic Oncology. He's also director of the fellowship training program in urologic oncology at Cleveland Clinic. And then finally, Dr. Jihad Kayuk, who's the director of the Center for Robotic and Image-Guided Surgery at Cleveland Clinic. He also serves as the director for the fellowship in robotic and image-guided surgery. And finally, he holds an endowed chair in laparoscopic and robotic surgery at Cleveland Clinic. I'm going to start by just presenting a couple introductory slides, and then we'll get into the question and answer session. So first of all, prostate cancer is a very common diagnosis in American men. Prostate cancer screening has been shown to lead to earlier detection of prostate cancer and can improve survival in men. And what prostate cancer screening typically entails is a blood test that's typically obtained annually called the PSA blood test, and a physical exam, which is performed by your physician. Most Cancer Society guidelines recommend men consider starting prostate cancer screening around age 50 to 55 among men who are at average risk of prostate cancer. Among men who are at a higher risk of prostate cancer, including men who have a first-degree relative with a history of prostate cancer diagnosis, the guidelines recommend starting screening at an earlier age, typically in a man's 40s. So we encourage all men to talk to their physician about the potential benefits of prostate cancer screening. Now I'll leave this slide up here again. This is our panel. As I said, throughout the session, participants can submit questions through the chat function. But to get things started, Dr. Haywood, maybe you could start off by telling us a little bit about surgical treatment options for prostate cancer and what that entails.
Sure thing, and thanks for that great introduction and a nice overview. So surgical treatment for localized prostate cancer is called a radical prostatectomy, meaning we take out the prostate, the entire prostate, and in many cases take out the lymph nodes that drain the prostate as well. These can be performed in several ways, sort of traditional open surgery, but also with laparoscopic or robotic techniques. Now, the strong majority of them in the United States and here at the Cleveland Clinic are done using the robotic approach. For those procedures, patients undergo surgery, and almost all patients are home within 24 hours, and sort of depending on the procedure and your surgery, might be the same day or might be an overnight stay, but almost all patients are home within 24 hours. There's a catheter that is left in the bladder for several days, and it's taken out, and the patient's allowed to urinate on their own. And with almost all the procedures, patients are back to their normal function within a couple weeks. And for the most part, I find patients telling me that they feel like it was a lot easier to go through than they had expected.
Thank you. Dr. Waite, maybe you could tell us a little bit about what sort of patients are good candidates for radical prostatectomy or surgical treatment for prostate cancer.
Sorry.
There you go.
Can you guys hear me? Thanks.
Yeah.
So the good candidates for radical prostatectomy are men who have cancer that's serious enough that if it's left untreated, it may cause trouble over their lifespan. And an interesting thing about prostate cancer is that not probably about half of prostate cancer cases, maybe even as many as 60%, can be safely watched. And so, it is, as opposed to many other cancers, when you get diagnosed with prostate cancer, the first question is always, does it need to be treated at all? And, and that's a question to discuss with your doctor if you are new to this. But we would typically say people who have intermediate risk or higher and have approximately 10 years of life expectancy left would be good candidates for treatment for their prostate cancer. And, if you're healthy and otherwise able to tolerate an operation, there are lots of reasons that radical prostatectomy is a good first approach for many men with prostate cancer, again, if it's kind of in that intermediate risk or higher.
And to follow up on that, Dr. Wade, do you mind just briefly going through the risk categories? I think that's an area of confusion for a lot of patients, and some of the questions that have come through, people are referring to, grades or Gleason scores. Maybe you could just cover that briefly as well.
Yeah, I'd be happy to. So for all cancers, we really use two scoring systems to try to help us predict the risk of that cancer. It helps us to know which treatments may be appropriate. It helps us to know what the likely outcomes are. And those are grade and stage. And in prostate cancer, the grading system is called the Gleason score. That's the historical system. It's an addition of two numbers, the two most common patterns of abnormal cells seen in the prostate. So that scale is a little bit confusing because the cancer scale really starts at 6 and it goes to 10. So so the lowest risk is a 6, but a lot of times it doesn't feel like that's the lowest risk. If you're told, hey, you got a score that's a cancer that's scored 6, it feels like that must be on a scale of 1 to 10. So part of the way that we've tried to help remedy that confusion is there's a newer scoring system called the Gleason grade group, and that kind of shifts that 6 to 10 system to a 1 to 5 system. And so a 6 becomes 1, a 7 that is a 3 plus 4 becomes a 2, a 7 that's 4 plus 3, and that means that there are more of the intermediate risk cancer cells in there than there are the low risk cancer cell pattern, becomes a 3, and then a 4 plus 4 becomes a 4, and then a 9 or a 10 becomes a 5. So that's the grading system. The other system we use is called staging, and the grading system is merely based on how those cells look under the microscope, but the staging system is based on where that cancer is located. So if it's kind of small and it's only located in one side of the prostate, that's typically a stage 1. If it's on both sides, but it's not grown out of the prostate, that's a stage 2. If it grows out of the prostate and in the surrounding tissue right around the prostate, that's a stage 3. And if it kind of extends and gets into the other parts or organs nearby, it moves it into stage 4. And so we use a combination of those, the grade group, the Gleason score, and the Gleason grade and the stage to understand which treatments are appropriate for men with prostate cancer. And prostate cancer, as we've alluded to, ranges from a very low risk cancer that you can watch for 15 years and never have any trouble with it without any treatment at all, to very aggressive disease where we still unfortunately are losing a basketball arena full of men every year to prostate cancer. So it really spans a big gamut, and it's important to kind of understand where your particular cancer falls on that spectrum.
Maybe to build off that, Dr. Wade, if either you or maybe Dr. Kayuk would like to just speak briefly about how prostate cancer is diagnosed and what testing men who are diagnosed with prostate cancer may have to undergo before, a urologist or a physician will be able to give a recommendation for treatment.
you want to take that one, Jihad?
Can you hear me now?
Yep.
All right, thank you. Thank you, Dr. Almasi, for hosting this session. You know, with our patients, this is a very common problem in men as we age. The question to me is about diagnosis, and the most important really is screening, adequate screening, a PSA and a rectal exam. That is the standard. But when there is any indication to go further, that would be with a biopsy. And the biopsy nowadays is done many different ways. Can you hear me? I'm having some noise.
I see it's a fire.
Okay. The most common is a transrectal biopsy of the prostate, where an ultrasound probe is inserted through the rectum, where the prostate is very close to the rectal wall anteriorly. And under ultrasound vision, one can pass a needle and take some samples and send them to pathology to be examined under the microscope. So that is the most common way, but this way evolved to become more precise, where MRI nowadays became very commonly done. So a patient will have an MRI, and that MRI will be imported into that ultrasound machine to do the biopsy. So we will overlay on top images on top of each other, one for the real-time ultrasound and the other for the MRI that gives you a pristine view of the tissue imaging. So if there is a suspicious area, we can precisely pass the needle to that area, thus increasing the precision of detecting cancer when indicated. That's what we do. Other ways that are evolving include the perineal biopsy. Perineal mean instead of going through the rectum, you pass the needle through the skin between the legs of the patient, where the prostate is about an inch deep from there. So you put the ultrasound probe as usual in the rectum, have a look at the prostate, have that MRI onlay, and then you pass the needle through between the legs, perineum. So these are some of the common ways, and by that we can get tissue diagnosis, confirm, if there is cancer or not, and then how aggressive, as you heard from my colleague, Dr. Way, the Gleason score, and that gives us a high, medium, and low risk categories. And based on that comes the options of treatment or no treatment.
Thank you. Another question that a patient had posed before the session was they had indicated that or their question was, what is the most effective or the safest treatment for a Gleason 6 or a grade 1 cancer? So presumably a low risk cancer. And maybe Dr. Haywood, you could start off by telling us a little bit about your thoughts on how to manage low risk, low grade prostate cancer.
Sure, I'd be happy to. And to be fair, the answer to that question is potentially all of them would be the safest treatment for lowest prostate cancer. Now, admittedly, that can make things very difficult for the patient and physician working together to decide. But in sort of the appropriate management, all of them have very, very good outcomes for managing low risk prostate cancer. Active surveillance, where we are watching the cancer very closely. Now, a lot of patients come in and they say, "Oh my gosh, you're not going to do anything," and I actually say, "No, as the name implies, with active surveillance, we are actively watching, actively working together to try and keep a close eye on this prostate cancer." Now, when we do that, we're checking PSAs, we're checking MRIs very, very closely, so that we know that if we ever notice the cancer to be more aggressive or higher in volume, that we can move at that time. And so, like I said, in sort of experienced hands, that can be done very, very safely with a extremely low chance of having any sort of spread while watching the cancer. Similarly, both radiation and surgery for prostate cancer all have very, very good cancer outcomes. And so what I tell patients when they ask me about it is you have to, talk to yourself and talk to, your trusted, partner or family member, whoever you talk to, and think about the side effects and which of the side effects would make your lifestyle difficult to continue, and that would help lead them in the right direction.
And then, Dr. Wade, maybe you could take this question. It's along the same lines, but a patient had written in saying that they were diagnosed with, grade 1 low risk prostate cancer, and were recommended active surveillance, but they were started on bicalutamide, which is an anti-androgen medication. So they were started on that treatment, and that is currently how they are being treated. Could you just tell us a little bit about, what your thoughts are on that, and whether or not that makes the most sense for someone with a low risk, grade 1 low risk prostate cancer?
Yeah, so a few details we know about men with low risk prostate cancer, that if that's truly all they have, if you truly only have grade 1 prostate cancer, the chance of dying from that is probably less than 1% in the next 10 years. So low risk prostate cancer is not lethal. Now, the problem is that we don't know for sure if the patient actually has low risk prostate cancer. When we do a biopsy, we're taking a sampling of the prostate and we're getting a representation of what's going on there, but we don't know exactly what's going on there. We're getting really only a small fraction. And so we want to reassure ourselves that we've not missed something more aggressive in there. And so that's where we bring in things like Dr. Haywood said, MRI, other PSAs, repeat biopsies, and often genomic testing. When we do that, we can get ourselves to a pretty comfortable place that indeed this is really low risk. If we really are convinced that the prostate cancer is just a grade group 1, usually no treatment is needed whatsoever. So not even bicalutamide. Bicalutamide and Lupron sometimes are used in this scenario if it's a localized prostate cancer. And the PSA goes down and everybody feels great about it, but it probably doesn't alter the disease course much if there is indeed just low risk prostate cancer. So at least in my practice, I tend to manage patients with grade group 1 after I've done a thorough evaluation and convinced myself and the patient that that's all we're dealing with, just with really close surveillance and no treatment at all.
And then sort of building off of that, maybe Dr. Kayuk, you can take this question. Someone had written in whether you believe that active surveillance is a reasonable option for someone who's diagnosed with a high volume of grade 1 or Gleason 6 prostate cancer. So by high volume, we mean multiple biopsy cores showed cancer, but the highest grade was a grade 1 or a low risk cancer. Is active surveillance still a reasonable strategy for someone with a high volume but low grade, low risk prostate cancer?
That's a great question to introduce me to my point I was going to make, following my colleagues' remarks. Gleason 6 is just a number. In medicine, we should not depend only on one clue to make a decision. You take multiple factors into consideration. When you say Gleason 6, face value, it's not really aggressive. The common sense is just observe it. It's not going to hurt you. But you heard from my colleagues that how can we be sure? But the first biopsy does not give you 100% accuracy. That's why a second biopsy, or sometimes called confirmatory biopsy, can have a 20% more detection of a cancer or more aggressive cancer. A Gleason 6 can mean something in a 1% of a Gleason 6, or high volume, as Dr. Almasi is asking me, with 50% or multiple biopsies, or other factors. Strong family history, for example, may be more meaningful than even the Gleason score. At what age is the patient having the Gleason 6? A 35-year-old is different than an 80-year-old having it. At what PSA? Was this PSA followed before and now it's still 6 but progressing to become higher volume? All these are factors that can impact what we do for a Gleason 6. high volume Gleason 6 just in general, will trigger more tests. Genomic testing, is it on the path of becoming more aggressive? I would like to know more before I can give you an answer and tell you, yep, continue on active surveillance, or no, let's go for treatment, being the different modalities that we may discuss later. So customize based on multiple factors. The answer in short is maybe. I will do genomic testing. If you only had one biopsy, I'll do another one. If you've not had an MRI, I will do an MRI and then take it from there.
And that's a really great point, sort of highlighting all the tools that we have to not only diagnose prostate cancer, but also to really define the risk of a given patient's prostate cancer. And one of the things Dr. Kayuk mentioned is something called genomic testing. And maybe Dr. Haywood, you could tell us just a little bit more about that. What does genomic testing involve, and how can that help us as we're deciding, whether or not treatment is needed, and if so, what treatment may be best for a given patient?
Sure thing. So, as my colleagues have discussed, the biopsy gives us sort of a snapshot of what's in the prostate. So we take samples of the prostate, but as Dr. Kayuk mentioned, how can you be sure that there's nothing more aggressive in there? And what we do with genomic testing is we try to get at the biologic behavior of the cancer. So, what we send over to the pathologist, they can look at it and they can say, what do we see right now? But the genomic testing aims to look at what genes are turned on or off in the prostate to really give us, is this like the wolf in sheep's clothing? Like, is there something that's destined to be bad in the future, even though it might not look as aggressive right now? And so, with that, the biopsy samples that have been taken get sent to the company. There's a couple different companies that are used, and they use some sophisticated testing to look at the genes that are turned on or off, and they send a report back to the doctor, and that testing gives us a little bit more of a risk stratification. So they might say, compared to the risk from the biopsy, this is more aggressive or less aggressive or similarly aggressive. And so it's another piece of data that can be used. So for example, that might be useful in the question that was posed to Dr. Kayuk, where you have a gentleman with a high volume, Gleason 6 prostate cancer, where if we have a genomic test saying that this might behave more like a intermediate risk cancer, then we might move towards doing treatment for it. Whereas if the genomics say that it's should behave less aggressively, then we might be more convinced to let that gentleman stay on active surveillance or try active surveillance for a period of time.
Great, thank you. Dr. Wade, maybe I can pose this next question to you. We have lots of questions coming in about sort of treatment options in different scenarios. So one question was, with a diagnosis of a grade group 4 or Gleason 8 prostate cancer, for someone who's in their late 70s, the question is radiation therapy with hormonal therapy, is that a reasonable option for treatment? And part of what the author is also asking is, if someone decides that a patient may not be a good surgical candidate, are there other non-surgical treatment options for localized prostate cancer?
Yeah, that's a great question, and a question we often meet with. So all of these treatments, you're kind of trying to balance the risks of the treatments with the benefits. And as we age, we're all at risk for prostate cancer, but we're also some of the treatments will affect us differently as we get older. And certainly someone in their later 70s is going to have a harder time with surgery, and particularly a harder time recovering their urinary control compared to men in their 50s or 60s. And so although surgery and radiation plus hormone therapy are comparable in terms of cancer control, and are both very good options, as men get older, the risk benefits may change. And I think if you're deemed not a surgical candidate, or if surgery doesn't seem like the approach you want to take. Radiation is a really good option. It has similar control to surgery. There are different side effects that you get from radiation compared to surgery, and many of them are delayed. So younger men maybe are more at risk if you have a side effect that shows up 10 years down the road. It may be much more meaningful if you're in your 40s or 50s than if you're in your late 70s. And so I think radiation is a great option. There are some other options like cryotherapy, which also can be used to treat prostate cancer. There are focal therapy options, which are different from surgery, although not a good option in kind of higher risk disease as the patient you propose. So I think hormones and radiation would be a great option for a guy in his late 70s for the prostate cancer. And it's also high enough risk disease that if you don't do anything about it, you may experience some progression of that disease. So I think it's a very reasonable approach.
And Dr. Wei, maybe you could just add, there have been a few questions about HIFU or focal therapy. Maybe you could just describe what focal therapy involves and maybe scenarios where a patient might be a good candidate for that treatment option.
Yeah, I'd be happy to. Most prostate cancer is multifocal, meaning it's not just in one part of the prostate, it's in multiple parts. But we know some prostate cancers are either unifocal, only one lesion, or there's only really one lesion that's problematic. The other lesions are benign or very slowly progressing. And so as we've gotten better, as Dr. Kayuk described a little bit about how we're using MRI to localize with more precision where the tumors are. Also, we've improved our biopsy techniques because we fuse it together with MRI. We've gotten a lot better, I think, at identifying where the cancer is located and where it isn't located. And if we have a patient who really has only one area in their prostate that has cancer and the other area we've probed and we know with pretty good certainty that there's not cancer there, then focal options are really a good option. And maybe I can talk a little bit about HIFU as a focal option, and then we can turn the time over to my colleague, Dr. Kayuk, to talk about a new, even newer, interesting option that we have here as well. But HIFU is essentially an acronym. We love acronyms in medicine. It's the acronym for high frequency ultrasound of the prostate. And we take this is delivered in the operating room. So you go to sleep, but no incisions are made. A probe goes into the rectum, an ultrasound probe similar to the one that a biopsy is done. But this probe has the ability to focus all the sound waves. This is just ultrasound, just like you've heard if you've ever seen an ultrasound on a baby, it's those same kind of waves, except for they're harmless when they are shot straight. But if you focus them all like a magnifying glass into one point, it really creates a very pinpoint high point of heat, and it can cause coagulative necrosis of the cell, or another way of, you could think of it as zapping, almost like you've got a laser gun and you're zapping that one particular point. And then you can kind of paint a bunch of these little points all the way around and then kill all those cells in that vicinity. And it's a newer option. Because it's so focused, the side effects tend to be less than some of the other treatments, but it is also potentially a compromise because you're only treating part of the gland, whereas traditional surgery and radiation will treat the entire gland. So if you do happen to have other cancers nearby, or if you don't happen to paint quite enough around that cancer, there's a potential of a slightly higher risk of recurrence. So here in Cleveland, we've been quite selective about who we're doing this on because we want it to be a good cancer treatment. And so we think it applies to about 10 to 15% of patients. We'll have just one lesion, a lesion that we can see on MRI. It's not too aggressive, but it's also not too benign that it doesn't need to be treated at all. And we're working on a clinical trial right now to kind of compare HIFU to what Dr. Kayuk is developing. Dr. Kayuk, you want to talk about what you guys have been working on?
Thank you so much, Dr. Wei. What our group at the Cleveland Clinic have been working on in terms of the surgical option is how can we decrease the morbidity, the pain, and make the recovery faster after surgery. So there is a latest generation robot that was released to the market late of 2018, and the Cleveland Clinic was the first to acquire that robot system in the United States. That robot is like a cannula, just a cannula with an 1.5 inch diameter. That cannula you can get all your instruments from. And what we did, we were able to eliminate the need for all the different cuts with the multi-port robot and make one cut to get into the prostate with minimal collateral damage, if we may say. Now that's for select cases. Again, there is no one size fits all. And that's why you have such an expert panel today with you, because we come with all different kinds of expertise that collectively we try to serve patients for their individual needs. So we try not to just say one procedure is good for everything. No, there are times where HIFU, as Dr. Ray was saying, or there are times where radiation or other modalities, are better. But in general, surgical approach is favorable for patients who have a life expectancy of 10 years and more. That's where surgery shine in terms of impact for the patient. And we can go into more detail if needed. Back to the panel.
Thanks, Dr. Cayuga. Maybe you can take this question as well. There have been a lot of innovations in surgical approach and surgical technique, and you've spearheaded a lot of this work. And so one of the questions was, are there newer surgical approaches or techniques that can help minimize the risk of long-term urinary incontinence after surgery or after radical prostatectomy?
Yeah, thank you so much. So there are, with the standard robot approach, there is some progress made towards less pain, quicker recovery, but we maximized it. So we need to move into somehow a different approach to break that barrier of the 90%, for example. And what we did with this new robot, because it's so much of a narrow profile, we were able to do the surgery from within the bladder for select patients. So instead of going into the belly, get the bowel out of the way to reach deep in the pelvis and operate on the prostate, we made a tiny cut just below the belly button and put the robot straight into the bladder, and there the prostate, you're looking at it. So that is the most direct way to get to the prostate and remove it and then suture everything back to normal for urine continuity. What we found collecting data over this year, we found that more than 70% of these patients are having immediate continence. That means we get the catheter out and they are dry. So that is an improvement to what we usually do otherwise. But again, this is for select number of patients with certain specific presentation. For these patients, we do the single port through the bladder and send them home the same day with a catheter that stays only for 3 days. And then when the catheter is out, they're dry basically, with occasional drop sometimes. So that is a improvement, and that's where we try in every aspect of treating prostate cancer to push the needle further towards less burden on the patient, quicker recovery of these patients.
Fantastic. Thank you. Dr. Haywood, for the next question, there have been a couple of folks who have written in asking about brachytherapy. Could you just give just a brief sort of summary of what that is? Maybe not everyone on the call knows what brachytherapy is, but if you could just give sort of a brief summary of what that is as far as a treatment option.
Sure. Yeah, so brachytherapy is one of the radiation treatment options that we have. entails a surgery, or it's a same-day procedure, usually using a radiation oncologist or a radiation oncologist with a urologist together. And what that is there's an ultrasound probe inserted into the rectum, and then we place radiation seeds into the prostate itself under ultrasound guidance. And so these seeds stay in; they are not taken out later. And over the first 6 months to a year, they release their radiation energy, and that radiation energy is what treats the prostate cancer. We have a lot of experience with that here at the Cleveland Clinic. I think we just completed our 6,000th case of brachytherapy. I think I saw the headline. And so for certain men, that can also be a very good treatment option for their prostate cancer.
Great, thank you. And then Dr. Wade, we have a question about surgery after radiation. So one of the specific questions was, is there a higher risk of incontinence with surgery after something like radiation or brachytherapy? So could you talk a little bit about that?
Yeah, so it is a more challenging operation to do afterwards. I kind of compare it to making a grilled cheese sandwich. If you want to take the cheese out, it's easier to take it out before you grill it. Once you grill it, you got to go back in and take that cheese out. You're probably going to take a little bit of bread. And what is that bread? Well, it's nearby. It's maybe the muscle nearby. The rectum is very close. So it's one of the reasons I really favor, if there's a high risk cancer, that maybe some of the high risk cancers maybe will need multiple treatments, surgery and radiation and hormones. The sequencing of those is certainly easier. Now, having said that, we can still do it. If radiation has occurred, there's a local recurrence, we can still do surgery after that, but it is higher risk both for rectal injury because it may be stuck to the back of the prostate, but also for incontinence. The urethra will be not as healthy and as viable. Radiation causes small vessel disease, so the blood vessels that go to those parts maybe won't have as good of a blood flow, and that blood flow is really vital for healing. So the risks are a little higher, and the incontinence risk is certainly higher, but it's still certainly doable. In the appropriate patient, we will certainly still pursue that because that may still be the best option for them if they've had a local recurrence after either brachytherapy or radiation.
Great. Another question that had come up was you talk about recurrence after treatment. How are patients monitored if they receive treatment for localized prostate cancer, let's say with surgery? How are patients monitored afterwards? What testing do they need? And can you describe maybe a little bit of that follow-up? Maybe Dr. Wade, I can give this one to you as well. Okay.
Yeah, so after surgery, we would anticipate the PSA should completely disappear, go to what we call undetectable. Every lab has their different undetectable level, but it's somewhere around 0.1 or 0.01. And if you've had surgery and your PSA is there, we're feeling really confident that no scan will find anything and that this is what we anticipate. Unfortunately, about 20 to 30% of people will have a subsequent rise after prostatectomy, but don't lose hope. I mean, that doesn't mean anything necessarily, especially if it's a very slow rise, or it rises and then falls and then rises and falls. Those patterns are not consistent with a recurrent prostate cancer, but a rise that continues to rise and in fact becomes measurable and doubles, especially if it's doubling in less than 6 months, that usually is indicative that there probably is some cancer somewhere that it got out before the surgery took place. In radiation, it's a different beast altogether because the prostate isn't out. And so when you're following up after radiation, it's a little trickier to understand what's going on because you still will have a PSA, it will go down. If you're on hormones, it will go down very low, undetectable most of the time. But once you stop those hormones, it starts to come up and you're not sure if it's actually cancer coming back or if it is just rising up to what it is there in the prostate still. So PSA is much harder to understand what's going on after radiation than after surgery. And, you know, the frequency of getting these PSAs is kind of dictated by how aggressive the cancer is. So if the cancer really is kind of on the low intermediate risk side or the low risk side, you know, a PSA maybe every 6 months, 4 to 6 months may be more than adequate. Whereas in intermediate or higher risk disease, you may want to do it every 3 months initially. But as we start to accumulate time after treatment and we're seeing that it's staying undetectable and we're feeling more and more confident, we start to spread those out and do them less frequently. And many men end up getting just a yearly PSA after that. And one last comment I'd like to add on that is a lot of primary care doctors don't know that a normal PSA after prostate is out is undetectable. And so we've had a few patients who have had their treatment and then they go off and start doing their follow-up with their primary care doctor and their PSA starts to rise, but the quote unquote normal value is all the way up to 4, and they don't get referred and they don't get told that something's wrong because their primary care doctor is believing, oh, that technically is normal, but it's not normal if you've had your prostate out or if you've had prostate treatment. And so it's important for men who have had prostate cancer to know that the only thing that's really normal is an undetectable PSA after a prostate surgery. And a rise even at a decimal place level is something to be paid attention to.
Great, thank you. Dr. Caillou, this next question is for you. So you talked a little bit about some of the surgical innovations and newer techniques that are being used to try to optimize outcomes with surgery and ease the recovery. And like you mentioned, some patients are discharged home the same day. You know, if they have a catheter in place, it, maybe removed 3 days after surgery instead of, a week, as in other cases. But some of the other questions relate to sort of what patients should expect after surgery in terms of how they're feeling, their activity level. Maybe you could talk a little bit about what you see with your patients in terms of what sorts of things they're doing the day after surgery, a week after surgery, and when they can get back to all the things that they're doing before they get treatment.
Yeah, thank you. So for robotic surgery, the expectations of hospital stay is 0 to 1 days, right? And the patients for single port usually go home the same day. The expectation is that they will have some pain that does not mount to needing narcotics. So we give them ibuprofen, some Tylenol, and by the next morning, the pain would be manageable just with Tylenol, if any. So that's for the pain. For activity, single port or not, the patient will be on their feet by the evening of the surgery and taking care of themselves. So they walk around, go to the bathroom. If the bedroom is upstairs, they climb the stairs carefully. There will be a Foley catheter to take care of. Regarding food, the first night we tell them to take it easy, just nothing, water, soup if they're hungry, and increase food by the next day. Heavyweight lifting remained the main limitation. The reason for that is the possibility of developing hernia where the cuts were made to put the robot instruments in. That's why usually we tell the patients to avoid heavyweight lifting for 3 to 4 weeks in general. However, with the single port approach, especially when we go extraperitoneal, that means we avoid the cavity where the bowel is. There's a sac that envelopes all the bowel. So you avoid that sac altogether and get straight to the prostate, being we call extraperitoneal or through the bladder. The risk of hernia is extremely low. So that's why I was encouraged to tell my patients you can go back to normal activity within 2 weeks instead of the 3 to 4 weeks.
Fantastic, thank you. I'll just make a note. I think we're coming up on just over 10 minutes left of the session. So again, please feel free to pass along questions through the chat function. I'm also going to advance the slide here. This just has a few resources. So, the website has more information on prostate cancer and treatment and ways to get connected with us. So please visit the website if you're interested. We also have an email address listed there. So if there are questions that you think of after this session or that we didn't get to today, you can always send an email to the address listed, and we'd be happy to help out. So please feel free to reach out. But in the remaining time, we definitely have time for a few more questions. One of the questions that came up, and maybe Dr. Haywood, I can pose this to you, was sort of what's the role of lymph nodes in prostate cancer? And for surgery, are lymph nodes removed, and why is that done, or how does that help us as it relates to prostate cancer treatment?
Sure, I'd be happy to answer that. So lymph nodes are structures that sort of drain organs, and they're sort of a collection of immune cells. And so we often will take them out in various cancer surgeries as both staging to see if their cancer has spread to them, and also that can be therapeutic as well, so that if there's cancer in them, then we've taken that out. In prostate cancer, the lymph nodes that drain the prostate are called the pelvic lymph nodes, and they're these packets of lymph nodes that are around the pelvic vessels. We take out the lymph nodes in many cases. Anytime there's intermediate or high-risk disease, we'll take out lymph nodes. For some cases of low-risk disease, some providers may do that as well. There is some controversy about it, and that the studies haven't shown a distinct survival benefit from that, but most of us think that it's a reasonable thing to do because it gives you some valuable information. If the lymph nodes are positive, that tells us something about the risk for recurrence, and also if there might be some benefit to getting some additional therapies afterwards. And overall, it doesn't add a whole lot of time to the case, and there's not a lot of additional risk associated with that. So, in my practice, at least for all intermediate and high risk cases, I will do lymph node dissection.
Great, thank you. Dr. Wade, maybe I can address this next question to you. One of the participants was asking about, how are the lymph nodes managed, or whether or not they're treated for patients who are receiving radiation treatment. Could you just comment briefly on that?
Yeah, so the lymph nodes cannot be treated with brachytherapy alone. So one of the forms of radiation, again, that we talked about is brachytherapy. Brachytherapy, you can only reach the prostate, and they give off just a very short burst of radiation in the immediate vicinity. Therefore, if there's a sufficient risk for lymph node involvement, really brachytherapy is probably not a sufficient treatment, and either need to consider external beam, which can be treating the prostate, or there's a lot of terminology out there as you kind of explore the different things that are types of radiation. There's what's called SBRT, which is kind of, you use higher doses and you deliver fewer doses. There is a wide variety of different ways to deliver radiation, but those external beam treatments where you lie on a table and they hit you with a beam, those can get the lymph nodes. So you can radiate the lymph node basins as well. And it's typically recommended, if you have a high enough risk cancer, that there's a reasonable percentage that those basins are involved, that you should either get an external beam dose in addition to brachytherapy, or just get external beam outright. And when they do the planning, they'll incorporate the node basins into their radiation field.
Great, thank you. I'll address this next question to Dr. Kayuk. Dr. Kayuk, we have a participant who was asking about urinary incontinence after prostatectomy, and the likelihood to need additional treatment for that in a man who's undergone surgery. And if someone were to need that treatment, are there treatments available for incontinence in men who have had surgery? So could you just talk a little bit about sort of the likelihood or probability of that after surgery, and if someone needs treatment, what those options may be?
Yeah, great question. We can take an hour to discuss that, but we'll summarize it. So surgery remove the prostate, and we aim at saving the muscle that gives the man a control after surgery. We can only save the muscle that is there. In men, there are two ways to have continence, the control of urine. One part is the prostate itself. It creates a bulk in the path of urine to the outside. And sometimes that can shadow the muscle, and the muscle will not be doing much at all for years. And when you remove the prostate, it's weak. We can only save the muscle anatomically. We cannot control the strength, the quality of that muscle. And that's why we ask every patient to start what we call Kegels or pelvic exercises even before the surgery, so that we can build the tone, the strength of the muscle that's going to be left alone to hold the urine without its long-time partner, the prostate, that will be removed in surgery. So that's why you will see some patients leak urine and some don't. Most patients will have in the immediate time uh,
Did we lose Jihad, or is that me?
No, it looks like the connect. Yeah, I lost him here too. Maybe Dr. Wade, you could pick up a little bit until we get Dr. Kayuk back. Just to mention briefly, about
The treatment
treatment.
options.
Yeah.
So if you are one of those men that ends up in that, it's a small percentage, but if you're one of those men that end up in that group that has a really hard time controlling the urine, even weeks or months after treatment, there are some options, which is really good news to know. There are two options if the incontinence is minor. Sometimes you can have what's called a urethral sling, where you have an outpatient procedure and the urethra is brought in closer contact to the pubic bone. Are you back?
I am back. I apologize. I have no idea what happened to my wife.
Uh-oh, looks like we're losing you again.
It just picked the wrong timing. So I don't know where you lost me.
We lost you just before talking
we-
about the treatment options, and I just mentioned the option about a
Can
sling.
have a. Can you hear me now? Can you hear me now? Can you hear me now?
Yeah, it's breaking up some still though.
All
Off and
right.
on.
Can you hear me without the video? I'm gonna stop the video sharing then.
Okay.
Yeah, that sounds better.
You can hear me now?
Yes.
Yeah.
All right. I apologize. So I'll keep my camera off just to work with the Wi-Fi here. There's a storm in the area. Maybe that's why. So there are two mechanisms to control urine in men, and one of them is the prostate. And when it's removed, the pressure all should be held by the muscle that we save. So that's why that muscle should be trained ahead of time. And one of the training is called Kegel exercises, where the patient will contract the muscle as if he is holding the urine. And we tell the patients to test that muscle. You will be surprised how many patients are not aware well of that muscle. So I tell them to do a test where they go and urinate and hold the urine midstream. That's only a test for them to confirm which muscle they will train before the surgery and after the surgery when the Foley catheter is removed till they are dry. There is a certain small percentage of patients who will not gain excellent urine control, and they will need further treatment that we can discuss on the panel. And that's usually about 2% to 5% of the patients. Remember that age also plays a role. Older men have weaker muscle than younger men. So the older the patient, the more the risk. Also, patients who've had radiation before. Radiation can hit part of that muscle. Thus, it may burn part of that muscle. I like Dr. Wei's analogy with the grilled cheese sandwich. So the grilling can get to that urethra. So when you remove the prostate, patients leak more, and that's why for what we call salvage prostatectomy, surgery after failed radiation, a big percentage of them would leak, no matter how good the surgery goes, and save that muscle. So, so there are different factors that can impact the urine control. Yes, it's not 100%, but it's pretty darn good after surgery, approaching 98% in general for primary treatment with surgery.
And that's really great, Dr. Kauk. And when you were having a little bit of difficulties, I just started talking briefly that if you are in that small percentage of people that it doesn't come back, there is a urethral sling operation, or what's called an artificial urinary sphincter. And usually between a combination of one or two of those, you will be able to regain urinary control. So that's also a great option for men to know about if you end up in that small group.
Yeah, thank you. Thank you. Yes, absolutely. And also, not only the Kegel exercises, some patients, we send them to physiotherapy. And that physiotherapy can be important because not every man can effectively train that muscle. It may sound easier than it really is. So physiotherapists can help and improve the results for that. Another factor we don't want to go too deep is what we call hyperactive bladder. Sometimes, especially patients who had weak urine before the surgery, that mean as we grow, also the prostate grows bigger, not from the cancer, for benign reasons, on top of having the cancer. So that makes the bladder very strong to push the urine through the obstructing prostate. When you remove the prostate, the bladder didn't know that, didn't get the memo. So it keeps pushing that urine strongly, forcefully through the muscle, and thus contributing to the urine control. For that subcategory, medicine can help. And we give a medicine that calms down the bladder till it resolves, because with time, that usually resolves over time.
Fantastic. Thank you. This has been a really great discussion. I think we're at the end of our time here today. So I just want to thank our panel again, for your time and the excellent input covering a very complex and broad topic. But, we hope that this was helpful to everyone who participated. So thank you to the participants who logged on and for providing your questions. Again, you can see on the slide here, we have some resources available, including some links, a phone number, and also an email address. So if there's questions we weren't able to get to, we're sorry we ran out of time, but please feel free to reach out to us. We're happy to help. And again, thank you to everyone who participated.